that this is a non-toxic thyroid nodule. So they don't have symptoms of endocrine dysfunction. Okay. So actually the most important component of any goiter, any thyroid disease, is the nodularity of the goiter rather than the functional status. In terms of the worst case scenario of that nodule is cancer. So you have to refer for fine needle. If you can do fine needle in your setup, you do that. You have to get the sample of the nodule. So if the nodule is benign, let's say the report of the cytology is benign, like I mentioned before, the next step, because your workup will not finish, because the looming diagnosis of cancer is still there. Once the cytology is negative, that cytology report is put aside. It's not going to be useful to you anymore. You still have a patient with a nodule here, which is potentially neoplastic. So we have to do the next step, which is lobectomy.
Why I'm asking is I've got quite a number of nodules around, people with nodules. But then after follow-up at GH, they just tell them to go back. Because in school, in medical school, we always say the potential of cancer, CA, no, for a thyroid nodule. But a lot of them have just left like that.
What can I say? So I cannot comment on that practice, but if the patient is alive after 5 years, 10 years, probably that nodule is a colored goiter in the end. Okay? That's by luck. Okay? But if that turns out to be CA, you will develop advanced CA with neck nodes and neck. The patient will need radical thyroidectomy or probably neck ablation by the head and neck surgeon. We want to do thyroidectomy, very early on, so that the morbidity and mortality is much lower.
I actually got what Dr. Haridas said was very interesting. I had bad experiences with thyroid nodules. The lesson to be learned is if you have a young female with a nodule, it's papillary C unless proven otherwise. I think this is one thing I learned. If you have a young individual, female, with a nodule in the neck, I would suggest please remove it. Yes, and that is that. Yeah. I don't know what the technique.
Yeah, actually, well, you mentioned that. If this in the literature in our practice, most patients with thyroid diseases are female. Most patients with vascular diseases are female. So for thyroid disease, if the spectrum of disease, benign to malignant, it's always a general trend. This is also being borne out in research also. So the chances of malignancy in a patient with solitary thyroid nodule is more in a male patient. So of course in the female we have to have that in mind also. But if it is a male, it is even more. We have to suspect cancer even more. Because the general thyroid disease in males is less common. So if there is going to be a goiter, solitary goiter, the chances of it being a cancer is very high. For some reason there is statistical rule.
I think in government settings because of the workload, they usually don't, they just give the patient follow-ups. I think it's more patient education. They don't actually advise the patient properly just before. Right? They must be told that you need to come back. There are signs of increase in size. It's what's most important. If there's any increase, then we are looking at some malignancy is going on. Okay. I think, we will close to
one more question.
Yes.
You have a patient who is having a goiter, multinodular goiter, and hyperthyroidism. When you send it for 131 radio ablation?
Okay, maybe that's one of the updates. I think I've not seen for the last few years. I've not seen a patient with toxic multinodular goiter undergoing radioiodine therapy anymore, because basically the treatment of multinodular goiter, if they are symptomatic, the best treatment now is total thyroidectomy, because basically after that we just give them a replacement thyroid. But they are hyperthyroid before surgery, And all these anti-thyroid drugs are good enough to really control the thyroidism just before surgery. So I've never seen for the last many years patients that need to be sent for radioiodine therapy as a preparation for total thyroidectomy. The only patient that needs radioiodine therapy in the current practice now is patients with differentiated thyroid cancer post total thyroidectomy, because when we do total thyroidectomy, there's always an assumption that there might be micro lesions that are missed. The near total I mentioned there. There's always a little tissue possible to be left behind, and the radioiodine is to ablate those residual tissue as an adjuvant treatment post total thyroidectomy. So for benign conditions, I'm not sure about other centers whether they still practice radioiodine to control thyroidism. Not in our practice. Our physician just give anti-thyroid drug, patient is ill thyroid, and we just operate.
Okay, thank you. Can you put our hands together and thank